there's one, but there isn't, I'm not going to suggest one right answer for everybody about it, but we'll walk through this on a couple of levels. We'll walk through it sort of on what this means for individuals, what a person making this decision during open enrollment should think about for themselves or their family. And then we'll also spend some time talking about a little bit about sort of what policies this would imply and possibly things that the League of Women Voters might want to focus on, and actually some advice on what maybe you don't want to focus on. So that's kind of the run of show. And
Right.
let me show you some slides. Um, I I realize that I actually have had dreams in PowerPoint. So I think the pharma needs to develop a drug for that, I guess.
That's
I don't know.
terrible.
So this is kind of the topic. We're going to talk about this piece of it, and it's so important because it's a major decision for individuals. It's a major policy decision for the future of healthcare in the country, and I'm just going to walk through it. But I want to start with introducing you to my mother-in-law. Um, Ma unfortunately passed away 5 months ago, so this is
I'm sorry.
a dated story now, but I just like looking at her. So there we go. And when she was living, I had her permission to tell this story, but her story kind of does have a lot of lessons about Medicare Advantage for us. So Ma, when she was about 82 or something, she lived to 94, and when she was about 82, she showed the signs of a rare genetic heart condition called HOCM, if you care, but actually very uncommon to begin with, and in somebody at her age, in her 80s, frankly rare. And it's genetic, and it's so I hope my wife doesn't have it. We don't know yet, but it's ultimately fatal. And it was at a point where she was quite sick. She was having chest pain all the time. She couldn't breathe very well. She could barely walk around her house, and she was clearly getting close to major, well, to passing from it. And it turns out it's treatable with an intervention, but it's so rare that hardly anybody knows how to treat it very well. And there's literally nobody in the state of Florida where she was living. There's literally nobody there that has focused on it as a thing that they've developed any real experience at. So, it's a rare, tricky thing. You don't want to go to somebody who's not used to treating it. Turns out that St. Louis, where I live, at Washington University, there is one of the three places in the entire country that does have a team dedicated to it. So we flew Ma from Florida to St. Louis. Hooray. She spent several days in the hospital. She did great there, and then she spent a few weeks recovering at our house, and that was great. And she lived for another 12, 13 years or so after that. Had two major orthopedic surgeries after that, which, I mean, she wouldn't have lived through any of that. So, hooray. And then something completely unrelated, was finally acted up a few months ago. Why am I telling you about her? First, because I just like talking about her, but secondly, because she had traditional Medicare and Medigap. So just to explain what that means, and we will a couple times, Medicare, 1965, the form of it was created in 1965, hence traditional, is Part A and Part B. So Medicare Part A is mainly hospital stuff. Medicare Part B is mainly outpatient stuff. And so when I use the phrase traditional Medicare, I'm referring to that, Part A and B. Medicare Advantage is completely different, and we will explain how it's completely different. But she had traditional Medicare and Medigap, and we'll unpack that too. But because she had Medicare, real Medicare, she could go anywhere. So we could fly her from from Florida here in St. Louis, and there's no other insurance in the country, I think, that lets you go so far out of your region for non-emergent care. But she could go anywhere. 89% of physicians accept adult medicine physicians accept Medicare as a payment model. So she could go anywhere she wanted. I'm the one who managed most of this stuff for her, and I never had to get any permission from anybody. I didn't have to call Medicare and get, can you let her do it? No permission needed. There we go. She had to pay nothing out of pocket because of her Medigap policy. So zero, actually, for her. And afterwards, when she went home for months later, She had zero surprise bills, and she loved it. And she trusted that it would remain there for the rest of her life, which it did. So hooray. So if you think about changing that product, if you think about messing up her Medicare, you get to deal with this version of my mother-in-law, and I have, and trust me, you wouldn't have wanted to. So how does Medicare work? Traditional Medicare? Well, it's almost this simple. You pay your taxes to the federal government, and then they send you the red, white, and blue Medicare card that you hold on to for dear life. And then Medicare itself pays your physicians and your hospital, the hospital you go to, and other stuff. So it's a little more complicated than that, but the basic flow of cash is like this. You pay taxes, you get your card, you go to whatever doctor or hospital you want, and Medicare pays them for you. Medicare Advantage is really completely different, and some would say it shouldn't be called Medicare at all, and it's unclear to me to whom the advantage falls. But Medicare Advantage is completely different. So instead of the Medicare paying doctors and hospitals, instead Medicare pays the insurance companies, largely the same insurance companies that employers often use. So Medicare pays them in advance of your needing health care. So they're prepaid a certain amount per person, which means that then it's in their pocket and they don't want to let go of it. So they're prepaid a certain amount for everybody that's in there, and then they pay doctors and hospitals on your behalf. Of course, they don't want to do that, but they do. They pay doctors and hospitals, and it's a little bit more complicated than that because they actually then can tell patients, oh, this doctor, not that doctor. Oh, this hospital, not that hospital. So it gets pretty complicated. And that's really kind of one of the key messages about Medicare Advantage is it's way more complicated than regular Medicare, than real Medicare. And it comes included, like I said, the red, green, black lines I drew. Almost 12 million people who are in Medicare Advantage are in a plan that excludes almost 3 out of 4 physicians in their county. Almost more than 10 million people in Medicare Advantage have an insurance product that will not let them go to nearly 3 out of 4 doctors in their county. Oh, that's not good. Traditional Medicare isn't anything like that. Medicare Advantage has all of the HMO stuff that we all have grown to hate, prior authorizations and such. Because they're prepaid, they really want healthy people because if you're healthy, they'll be prepaid for you, but they won't have to spend any money on you. So they have tricks designed to attract healthy people and not to attract sick people. They operate with tremendous overhead, about 15% overhead and profit compared to 2% for traditional Medicare. And despite that, they're funded, as I'll show you near the end, they're funded perhaps 35% more per person than the same person would cost in traditional Medicare. They've 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 rigged the system so that they get paid 35% more than the same person would have cost in traditional Medicare. So, as I said right at the beginning, this is a trade-off. There's no automatic what's best for any individual in my mind. But looking just at the current data, traditional Medicare, again, most physicians across the country are covered. There's almost no prior authorizations required. There's a deductible for hospitalizations north of $1,600 every time you're hospitalized with that. There's a copayment for every bit of outpatient care. So if you go to the doctor once a year, it's not that big a deal. But if you're sick and you're going every week or maybe multiple times a week, 20% copayment for outpatient care can bankrupt you. And these numbers, the deductibles for hospitalizations and the copayment for outpatient care are without limit, without limit. I mean, literally there's no maximum on that. So if you have traditional Medicare and haven't done anything about this, there's no end to how much that can add up to. And then it doesn't come with a pharmacy benefit, Medicare Part D, hooray, but you have to pay a premium for that. That's not part of Medicare, of traditional Medicare. It also doesn't include hearing or vision or dentistry. And so what most people do who are in traditional Medicare is they buy Medigap if they can, and then that'll eliminate the copays and deductibles. It won't add hearing, vision, or dental usually. It won't add pharmacy usually. But if you buy Medigap, at least you're not going to go bankrupt from the copays and the coinsurance. So what is Medigap? It's a commercially run program. It's not run by the federal government. It's commercially run. And there's a whole menu of Medigap choices. If you go to the Medicare.gov, as I'll point you to near the end, there's a whole alphabet soup. And I'll simplify that for you. Almost everybody today who goes to Medigap decides that Plan G for good, Plan G for good, if you're going to pick a letter from the soup of Medigap plans, almost everybody comes to the conclusion that Plan G is the one. So you can just go straight to those. And if you get that, if you get Medigap, then the copays and deductibles disappear after you spend $240 on a deductible every year. So no more copays or deductibles. So that's the biggest problem. And you have to pay for it, though. And the average premium is about $175 a month in 2024. If that's too much, if you don't want to spend that much, there is a high deductible version of Plan G at the same place. And that has a much lower premium, but it has a higher deductible. So it's a trade-off you can make. Medigap almost never adds any other benefits, so it doesn't give you hearing, vision, or any of that stuff. And the trick is that you're not guaranteed you can get Medigap after you've been in Medicare for 6 to 12 months. So when the ACA was enacted, it did away with pre-existing conditions. If you buy insurance on the ACA marketplace, the insurance companies have to sell you a policy. They can't ask you how sick you are, and hooray. And most people think that that worked for all of health insurance, but it did not apply to Medicare. You didn't know that. It did not apply to Medicare. So if you're in Medicare and you want to buy Medigap, as I just said, most people should or do if they can, you're guaranteed that you can buy that without a health survey questionnaire, without being underwritten or whatever. You're guaranteed you can buy that for the first 6 months that you're in Medicare Part B, or they extend it to 12 months if you're in Medicare Advantage. But after you're in Medicare Advantage for more than 12 months, there's no promise, except for in 4 states, and Colorado is not one of them. There's no promise that you can get a Medigap policy. So the choice basically is between traditional Medicare plus Medigap plus Medicare Part D. That's the choice. That's the choice I made. That's what I have. And I spend about $250 a month doing that, $200 for my Medigap and $50 for my Part D. So I did that, or Medicare Advantage. And I chose not to for a few reasons that I'll show you. But Medicare Advantage, where I live, you can buy it for free. You can join Medicare Advantage for no premium. The average premium for Medicare Advantage around the country is $18 a month. But $250 for traditional Medicare plus Medigap plus Part D, or nothing for Medicare Advantage. It's kind of important. So what is Medicare Advantage? It covers the same range of services as traditional Medicare. It's required to. I'm not sure it does, but it's required to. We'll talk about that. All of them include a pharmacy benefit. Almost all of them include some version of hearing, vision, and dental insurance. Most of them do. And they, like I said, come with 0 or very low premiums. They do have an out-of-pocket maximum, unlike traditional Medicare. They have an out-of-pocket maximum statutorily of $13,000. Quite a bit of money. Almost all of them are much lower than that, though. Most of them, the average out-of-pocket maximum in Medicare Advantage is a little under $5,000 for care that's in the network that they want, or as high as almost $9,000 for out-of-pocket maximum for in and out of network. But in general, Medicare Advantage plans have a $5,000 out-of-pocket maximum for in-network care. Each one differs, but about $5,000. And again, no out-of-pocket maximum in traditional Medicare. But because it has that out-of-pocket maximum, you're not allowed to buy Medigap if you're in Medicare Advantage. Is that good or bad? And then, of course, one of the bigger problems with Medicare Advantage, or challenges or decision points, is that they have far fewer physicians that they'll let you see. And they have these lists of physicians that's actually kind of hard to find and unpack. And they can change it during the year while you're with them. And perhaps most importantly, prior approvals are rampant in Medicare Advantage. Every one of them, I think, requires prior approvals for something, and many for most things. So that's a lot. This is complicated, and most people don't think all of these issues. And nobody can do that. So what people do is they prioritize these things. If people who are attracted to traditional Medicare, these are the things that attract them. They like the fact that they can go to almost any doctor. They like the fact that there's no prior approvals, and they like the fact that they can buy Medigap if they can, so that they don't have any out-of-pocket costs after the deductible. Of course, that's a downside too. So they have to pay a premium for that. They don't doesn't include pharmacy. It doesn't include hearing, vision, or dental. So those are the things most people think about when they're thinking about traditional Medicare. In Medicare Advantage, most people are thinking primarily about that it's the same range of services theoretically, and the pharmacy benefit, and some hearing, vision, or dental, and virtually no premium. And what, of course, the downside that they trade off for the no premium and the extra benefits is fewer physicians that they can choose from, and way more issues with needing to get approval for things. So that's kind of the trade-off. And like I said, there isn't a single right answer for everybody on what they should decide to do. And nobody, I don't think, should feel like they have to bear the weight of national healthcare policy on their own personal wallet. Nobody should think they if they think that there needs to be a national policy change, don't feel like a traitor because you're choosing for a plan that's not aligned with what you think the national policy is. That's not how we're going to get there. So you have to make the decision that's best for you. So you have 1 year to change your mind. Like I said, technically anybody can always leave Medicare Advantage if they want to and go back to traditional Medicare during open enrollment, but there's no guarantee of getting Medigap because the pre-existing conditions come back online. And so after that first year, you can switch, but Medigap doesn't have to sell you a policy, and so you're kind of trapped. So most people can't really afford to leave Medicare Advantage, or may not be able to afford to leave after their first year that they're there. So I showed you the kind of trade-offs. Most people are at this point kind of deciding that Medicare Advantage is a trade-off that they're willing to make, partially because they don't know the things that we're going to be talking about, but partially because it's arithmetic for them. And now it is indeed the majority of people in the country. You can see that it's kind of been spreading around the country. The United States versus Colorado. Colorado in 2014 was 35% Medicare Advantage, and today it's 56% Medicare Advantage. So you're a little bit more than the average in the country. And, I'm going to show you some things that I'm concerned about with it. But to be clear, people in Medicare Advantage and traditional Medicare are fairly comparably satisfied. In part, that's because most people don't need to use their insurance that much. But in general, the satisfaction letters ratings between the two are pretty comparable. So if somebody's out there in this call and is saying, "Hey, I got Medicare Advantage, it's not so bad for me," you're not alone. A lot of people actually have pretty comparable experiences with Medicare Advantage, and that's why this is genuinely a decision and not an automatic answer. But there is more to this story. Let me give you a little bit more here. The first is, they cover these extra benefits. Eyeglasses, they all have some form of eyeglasses, and all these other things you can see there. But I want to unpack one of these, at least the dental one, and maybe that's because my father and brother were both dentists. I don't know. I want to talk about the dental benefit. So a lot of people actually join Medicare Advantage because of the promise of dentistry, and it's a big deal. People really want and need a dentist. And 24% of people in traditional Medicare tell us that they are unable to access dental care because it's too expensive. Remember, traditional Medicare doesn't have a dental benefit. And a quarter of the people in traditional Medicare say they can't get in to a dentist because it's too expensive. And Medicare Advantage, one of their selling points is that they have a dental benefit. So of course that's better. Oh, wait, it's worse. As it happens, people in Medicare Advantage, despite their having a dental benefit, almost all of them have more financial problems accessing care. Now, let me just kind of fully disclose, this is a little bit misleading because people in traditional Medicare are a bit wealthier than most people in Medicare Advantage on average. So, of course, they're more able to afford things than people in Medicare Advantage. So I don't think you can compare those numbers exactly. But when Medicare Advantage companies are promoting themselves as offering a dental benefit, recognize it's a pretty crummy dental benefit. And by that, I mean, they have very limited networks of dentists. Some people have to travel 100 or 200 miles to find a dentist who's in network. And so people still, despite having this, pay out of pocket because they have to go outside of the dental benefit network. And it's not an unlimited benefit by any means. It's a benefit that the majority of these benefits stop paying anything after $1,000 of healthcare for a year. They usually, other than for cleaning, they usually require something like 50% payment by the patient. So again, not really affordable. That's why the 30% number is there. And they won't even cover anything typically. Certain things that, because pre-existing conditions absolutely exist in the dental benefit. And then they have a whole bunch of things they simply won't even cover at all. So that's what I mean when I say that, yeah, it covers dentistry, but it's a pretty limited dental benefit. Medicare Advantage also has almost all of them require prior authorization for various things, as you can see on this list here. Um, and those are troublesome. They delay your care if you can even get the authorization at all. Turns out, just looking at Medicare Advantage, there were 35 million prior authorization requests in the year that we looked at. 35 million just from Medicare Advantage. That means we did the arithmetic. That adds up to 20 million hours of medical office time. Physicians and their staff spent 20 million hours a year on getting the prior authorizations just for Medicare Advantage patients. Imagine had that time been spent on something that actually improves health. Um, of that 35 million requests, 10% of them, almost 10%, are turned down. 3.4 million MA requests were denied, and only 10% of those denials were ever appealed. Only 10% of the denials in Medicare Advantage are appealed, and almost all of the appeals win. Almost all of the appeals win. Does that mean that all of those denials would have been approved? No, because probably you're more likely to appeal if you've got a really good case. But the point is, very few people appeal, and those who do, it wins. So here's a tip. If you think you have something that they've denied that you think Medicare would have paid for, do the appeal. The chances are, if you have something that really kind of makes sense at all, chances are if you appeal, you're going to win. It'll take a lot of time. You may not get it when you want it, but you will win in Medicare Advantage. Traditional Medicare is really quite different. They only have three categories of things that they do prior authorizations for. They're all relatively marginal things. And you'll see that they're turn around very quickly. Medicare Advantage takes usually a week or two to approve something. These turn around in just a few days. Hooray for big government. It works really well for this. And virtually none of the appeals are ever approved because Medicare, traditional Medicare, if they deny something, they're just doing it by the book. It's extraordinary for them. Maybe if you appeal because you know something that they don't know about your health, those are the ones that get overturned. But if it's just an appeal, you're not going to win in traditional Medicare because they did it properly. Medicare Advantage did it not because it's clinically appropriate. Medicare Advantage denies your care because they don't want to pay for it. So it's a difference. So we said that there's people in Medicare have trouble accessing care because of cost. This is, of course, and it's worse in Medicare Advantage, surprisingly, given the out-of-pocket max, it's worse. But people in traditional Medicare of Medigap have far less trouble accessing care because of cost. It's true across races. And of course, as everything in the United States is, it's worse if you're Black. What about income? How much of this is driven by income? Well, that was looked at too. And if you look across all income levels, of course, people in traditional Medicare across all income levels have fewer problems accessing care because of cost or having medical bills or debt. Lower income folks often have dual eligibility and have Medicaid along with it, so they have less of a difference between Medicare and Medicare Advantage. It's medium income folks who have the biggest difference. So mid-range income people, which is between 200 and 400% of the poverty level, mid-range income people, there's a big difference in medical debts and bills between traditional Medicare and Medicare Advantage. With Medicare Advantage, have people having a lot more trouble with medical bills and debt. The only group that isn't bothered by this are people who are more wealthy because, they don't that's not as much of an issue when you've got a lot more money on your hands. So, how can it be that there's these out-of-pocket expenses in Medicare Advantage? How can that be? Actually, I'm going to skip this for time. Sorry. So let me just kind of skip to the next chapter here and introduce you to another friend of mine, another dead friend of mine, Lefty, John O'Rear, ironically, an insurance broker in rural Missouri. I promise you, everybody in this room would have loved him. He was great. But at age 64 and a half, when he had commercial insurance, he developed esophageal cancer, which, as you may know, is something you really, it's on my top 10 list of things I don't want. He developed esophageal cancer, and his commercial insurance company, he wasn't Medicare age just yet, but it would have been the same thing had he been in Medicare Advantage, because they do this too. His commercial insurance company would not let him go to a center of excellence. Now, if you have appendicitis, probably any surgeon in the country has got enough experience at that they can usually do a good job. If you have esophageal cancer or some other uncommon but severe things, you want to go to somebody that's really experienced. And his insurance company made him use the local doctor that he had in rural Missouri, and not sure that that was the best choice. And then at age 65, he got into Medicare and he purchased Medigap, and we were able to connect him up with world-class experts here in St. Louis, actually. And his phrase was, "I've got the keys to the kingdom." And actually, his plan when he finished and recovered from this was he was going to go on a speaking tour with me that he wanted to call "The Keys to the Kingdom," because he was on board with this, but he missed the window to treat his cancer. Not sure that there was one. Esophageal cancer you have to catch right at the beginning, and we have no way of knowing what would have happened had he gotten better care right at the beginning. But it infuriates me that he was precluded from getting a shot at that. And it's not just him. It's not just him. He was a great guy. It's not just him. That's true in traditional Medicare versus Medicare Advantage. If you look at how long it takes to get from diagnosis to treatment, Medicare Advantage patients wait longer across the country for cancer. For cancer, Medicare Advantage patients have to wait longer to get treated than do people in traditional Medicare. And they don't tell you that in the ads. They have to wait longer, and they don't get to go to the best places. Medicare Advantage patients, not everybody wants to go to one of the best places. They're far away, they don't like that place or whatever. But if you want to go to one of the best places in the country, that should be your decision, especially if you haven't, everybody should be able to do that. So it turns out Medicare Advantage
Not everybody
patients
can do
are seldom able to
that
go
with
to
them.
one of the best places. So is this all important? Delays in care and being prevented from going to the best places? Yes, they die. Yes, they die. People in Medicare Advantage are more likely to have actually have in some cases twice the chances of dying post-surgery than do people in traditional Medicare for cancer. So, and the networks are narrow, and the delays in care, both of those things are because the Medicare Advantage companies want to make more profit off of you. And so they're willing to make more profit off of us at the expense of literally killing us. And that's just not the way I think a healthcare system should be set up. And in theory, we're putting up with this because they're saving money for the country. We know how expensive healthcare is. And so their mission was to save money, and then specifically to save money by improving the health of the country. They told Congress in 2003 they would improve the health of their members and therefore save money. And sadly, every year since they were created, they have cost more than traditional Medicare does. They have never generated savings. All sorts of reports demonstrating that. I'm just going to do a high level wonkiosity for like 2 minutes on this. So, take a deep breath, and I'll do it quickly, but I want to show you for a reason. I want to show you how they are overpaid. And there's four specific games that they play. So the first is upcoding. I said that they're prepaid for you per person. And they said, hey, these people are sick. We need to be paid more if they're sick. Well, that's kind of reasonable. So they set up a system where if somebody is sicker, the capitation rate is higher. So all of a sudden, the game became pretending that you're sicker. So they scour your chart for more diagnoses. They send a nurse out to your house to come up with diagnoses that have no clinical meaning, no clinical value, but all of that is sent in to increase the amount they're paid to the point of $20 billion. So 20 billion of what they're overpaid is just by pretending you're sicker than you are. And then they avoid sick people, as I said earlier, for reasons, but they're paid for average people. And so this favorable selection is another $45 billion that they're overpaid. They're paid for average, but they're not getting the average patient. They're getting healthier patients. And then there's this series of benchmark adjustments and bonuses that have consistently been described by everybody, by almost everybody who's impartial, as having no real value for the system, and that's another 25 billion. We can talk more about those if you want, but there's a handful of those. We lumped them together as 25 billion. So if you just look at those, upcoding, favorable selection, and these other things, you're at about $100 billion of extra. And then there's one other subtle but really important one. They're paid, they're prepaid. This capitation is based on the cost of the average person in traditional Medicare in their county. It's based on the cost of the average person in traditional Medicare in their county. But remember, most people in traditional Medicare have Medigap. So most people in traditional Medicare don't have financial barriers to going to get health care. But if you're but Medicare Advantage companies are prepaid based on people who don't have financial barriers to care, and yet Medicare Advantage companies, as I've shown you, do have financial barriers to care. So people don't use as much health care as they do in traditional Medicare, but they're paid as if they do. And that's another $36 billion because this whole payment model is screwed up. Anyway, if you add that up, it comes to anywhere from 80 billion or so to as much as 140 billion, which is, as it turns out, a lot of money. And that's how they pay for those extra benefits. That's how they can pay for eyeglasses. That's how they can pay for the pharmacy and these other things that make people pick. So those tens of billions of extra dollars are how they can fund those extra benefits that make themselves grow. So we're overpaying them so that they can have marketable things and grow. I like one of my favorite humans in the world, Don Berwick. Dr. Berwick said, if an ice cream firm can offer free ice cream because of a subsidy, well, of course its market share will grow against companies that have to charge for ice cream. But that's not because they have better ice cream, it's just free ice cream. And that's why Medicare Advantage is growing so much. Plus, they, of course, lie to us. The Senate, a couple of years ago now, not quite 2 years ago, did this big report about deceptive marketing practices. And I love this little ad that I found. Get quotes from unbiased licensed agents. Unbiased licensed agents, and a third of us decide to what to do about Medicare Advantage from an insurance agent, and they call themselves unbiased. That's hooey. There's all these ads that you'll see that look like they're ads for Medicare. They have these phone numbers, attention Medicare. They're not Medicare. They're not Medicare. The phone numbers look like they're Medicare, but they're not. These all send you to an insurance agent, not to Medicare. And you'll get things in the mail like this. This looks like a tax form, On first look, this looks like, oh, it's one of those tax forms. I better fill it out and send it back in. This didn't come from the US government. This isn't a tax form. This came from a Medicare Advantage company that wants to enroll you. So you'd fill this out thinking you're doing your duty as a taxpayer, and then without even realizing it, you've signed up for Medicare Advantage. That's not right. And they will outright lie to you, the insurance agents. Medicare did secret shopper calls of insurance agents a couple of years ago, and most of the calls, 80% of the calls, were either inaccurate or misleadingly insufficient. And my personal favorite, perhaps because of my life in Express Scripts, was this one where there's dozens of them, but there's this one. Oh, not to worry. If your medication isn't on Medicare Advantage as a formulary, your doctor can just call Medicare Advantage and they'll just add it for you. Don't worry. That's just a complete lie. Why would they lie like this? Why would insurance agents lie like this? And I'm here to tell you, I've got a couple friends who are insurance agents, and they are very reputable, honest, high integrity people. And so they're not all they're not all prone to these financial perversities. But here's the problem. Here's the problem. If a Medicare Advantage company gets you to sign up if an insurance agent gets you to sign up for a Medicare Advantage company, they get $600 from the Medicare Advantage company. And then the next year, if you don't make a change, and if you haven't gone to another broker and you just kind of stay put, no extra work, the next year they get $300 for you still being there. And the next year, $300. And this is their retirement strategy. There's like literally seminars for insurance agents about how to build their retirement portfolio by selling Medicare Advantage. And notice that that's twice as much money as they get for selling Medigap. So tell me that they have no conflict of interest. They are very conflicted, and they don't disclose this to you. Then the other sort of arcane little detail here is to notice that there's very relatively small commissions for Part D. This just really gets my goat, because when you talk to your insurance agent, they'll help you through Medicare Advantage versus Medigap, because that's where they make their money. And then you'll tell them, okay, well, now help me with a Part D plan. And they'll say, oh, yeah, you can, that's really easy. Just go to Medicare.gov and you can pick that out on your own. That's really easy. Turns out, if you go to Medicare.gov and try to pick out your Part D plan, that's really difficult, because there's a lot of them and they all have different formularies. You can't find the formulary easily. You can't find which drug is on their list. It's hard to find what pharmacies they'll use. It's complicated. It's not easy. Medigap, go to Medicare.gov, check the box for a supplement Medigap, look for the G's, plan G for good, and then pick the cheapest one, because they're all the same. That's easy. But the insurance agents don't make, they make their money off of getting you to buy Medigap or Medicare Advantage. So what should we do about all this? Well, the first thing is Medicare Advantage companies should no longer be favorably advantaged in the marketplace. So they said that they could save the country money by improving our health. So let them do that. They shouldn't need a subsidy for that. They shouldn't be paid 35% extra. And nobody should be trapped in Medicare Advantage because they can't afford Medigap. So one policy that we need to really fight for is to introduce an out-of-pocket maximum in Medicare Part A and B. And then that would roll across to all of Medicare, actually. But there should be a $1,000 out-of-pocket maximum in Medicare. And then you wouldn't need to buy Medigap, because why would you buy that? And if $1,000 is too much, chances are you're at an income level where you're qualified for Medicaid in most states. So the single most important thing we need to do to make it a level, fair competition between traditional Medicare and Medicare Advantage is to have a low out-of-pocket maximum introduced. And as you know, there is no out-of-pocket maximum in traditional Medicare, which is why you have to buy Medigap, which is not easy. So at the same time, we need to stop subsidizing Medicare Advantage. It's crazy. That's not what they promised. They promised that they could save money by making us healthier. So let them make us healthier, and we should stop subsidizing them. And those are things that the League of Women Voters can get engaged in. There's a specific advocacy opportunity on that one, which is the Medicare Advantage rates are redetermined every spring, February and March. There's a whole process for how that happens. Medicare releases numbers that their actuaries produced. There's a month when we can comment on that. Insurance industry weighs in on that, and for almost every year has persuaded Medicare that the numbers Medicare's actuaries produced are not high enough. And so almost every year, Medicare then jacks up the payments to Medicare Advantage beyond what Medicare's actuaries said was appropriate. Last year, PNHP and our friends at Be a Hero and Social Security Works and Public Citizen and People's Action and a few other groups, we descended on Congress. PNHP physicians led 44 meetings with members of Congress and their staff last year and got them all to encourage CMS, Medicare, to hold to the actuaries' numbers and to not accept the industry numbers. And it worked. The first time in more than a decade, Medicare put out their draft that was created by their own actuaries, and we descended on them, and industry really descended. And Medicare, knowing they had some political support this time, the first time ever, Medicare did not go up above the rates that their actuaries said. And this had a huge impact. Hundreds of billions of dollars of stock value for the Medicare Advantage companies disappeared over the next week. Their stock prices plummeted because they were woe is meing. They were, we're not going to get quite as much of an increase. They still got an increase. The actuaries increased it, just not as much as the Medicare Advantage shysters thought they should. So we held them flat last year. Hooray for us. And this coming year, we're going to have to double down because the industry is doubling down even more. The insurance industry has said that they're going to spend at least a seven-figure number advocating for their rates to be increased above what Medicare is going to come out with. And they said that before Medicare said what they're going to pay them. before Medicare announced what they're going to pay them, the insurance industry said that's not enough. We're going to have a seven-figure campaign to get more than that. But they haven't even said what the number is. And so my point is, you betcha PNHP is going to be jumping all over Congress in when those numbers come out. And we'd love to be joined at the hip with League of Women Voters, getting meetings in all over the country with members of Congress. So pay attention to that. That's coming up. That's a huge, really practical, if we can make Medicare Advantage less profitable to them, then they would be forced to do what they promised. They would be forced to make money by making us healthier instead of by killing us, instead of getting overpaid for killing us. If they can make money by making us healthier, I love them. I love them. So let them do what they promised. And then while we're at it, once we do those things, we should of course do these other things. Lower the age for Medicare eligibility. And I believe there's going to be a bill submitted in the next week or two to drop the age from 65 to 60, and add in hearing and vision and dental and all that stuff. Add that in. I'm bringing that up because there's some really important strategy on that League of Women Voters needs to know about that. First thing I want to point out is if you lower the age of Medicare, but don't add in the out-of-pocket maximum, what you're going to do is drive people into Medicare Advantage. If you lower the age to 60 and don't put in the out-of-pocket maximum, most of those people are going to go into Medicare Advantage and strengthen the arm of the insurance industry. So, we love the idea of lowering the age of Medicare eligibility when it's done in concert with these other things. It's got to be done sort of in lockstep and in synchrony. So, yes, lower the age, but yes, also be sure we have that out-of-pocket maximum. The other similar piece is if you add in those extra benefits, hearing, vision, and dental, without cutting the subsidies, you're going to increase the profits for Medicare Advantage. Let me explain that. So how do they pay for hearing? How does Medicare Advantage pay for hearing, vision, and dental today? They pay for it by the excess from the subsidy that they get, their benchmarks that are jacked up $140 billion, that $140 billion extra that they get because they're overpaid. Out of that overpayment, they add in hearing, vision, and dental and all that stuff. So kind of out of their own money that they're paying for that. And they do it because, of course, it's got market value. It makes them grow, but they're paying for it without direct funding for it. If you add hearing, vision, and dental and pharmacy into all of Medicare as a required benefit, well, then the benchmark to Medicare Advantage will go up to pay for that. So Medicare Advantage companies today are paying for hearing and vision and dental out of their own, out of the subsidies. If you add it into all of Medicare, they'll no longer have to pay for it out of their subsidies, and they'll be able to retain more of those subsidies to do other marketing gambits. So, of course, add in these extra benefits, but we need to do it in lockstep with cutting the subsidies, or you wind up again inadvertently strengthening the profit margins for Medicare Advantage. So all we're saying is they promised they could save money by improving care. They've been saying that since 2003. Let's just see them. Let's see them do it. So kind of a little bit back to work. How do people make these decisions? Where do you get advice? Don't turn to an insurance agent. They are not a good source in my mind. Medicare.gov, if you like using the web and you're on the Zoom call, so you probably do. Medicare.gov is a really easy to, in my mind, relatively easy website to navigate. It's as unbiased as you can get, although I think they're a little bit leaning towards Medicare Advantage, but they're relatively unbiased and they're certainly accurate. You can easily compare Medicare Advantage with traditional Medicare side by side. You can call them on the phone, 1-800-Medicare. That is the only phone number, 1-800-Medicare. All of the other phone numbers on TV are to an insurance agent, for better or worse, so don't believe them. Or if you need in-person stuff, there is these things all over the country called State Health Insurance Assistance Programs, or SHIP, S-H-I-P. And these are a network in every state. The network is federally funded, so the U.S. government funds these networks in every state, and in each state, they're staffed almost entirely by volunteers. So, hooray for those hardworking volunteers. And the volunteers are all declare themselves free of any conflicts of interest. That's the QR code to get you to the SHIP program for Colorado. But all of them are at shiphelp.org. So they have no conflicts of interest. They really care about it because they are volunteers. They're usually pretty well informed. They're usually, but there's some variation. They're nonprofit. They're free, unbiased. They're completely confidential, and they don't sell you anything, and they won't sell your information. So they're a really good resource to know. Then the other resource to know is PNHP has this website we've built called Heal Medicare, and there's a lot more information about Medicare Advantage on there. So go to healmedicare.org or follow this QR code. We have a survey that we're still collecting data from, so it'd be great if you could fill that out. We have a petition voicing our concerns about Medicare Advantage. And if you're a physician, or if your physician expressed any interest in this, to point them to healmedicare.org. Ask them to also take our survey. And I think, yep, that's it. So good.
Awesome.
A lot of information. Well, we got a few minutes to talk.
Yeah, we do. There's a couple of comments in the chat that I'll mention in just a sec, but I also wondered, Doctor, if you could comment on the trend for private equity to buy and manage Medicare Advantage plans, and of course, their whole motive is profit.
We should outlaw that.
We should, right?
That's terrible. I mean, that's terrible. That doesn't work in any industry. That's just, it's a terrible. So yeah, I agree. I saw some questions about whether states should fight for guaranteed issue and community rating. I actually have slides on that I might show you that I made for this, and then I decided it was too much detail. So let me let me show you my thoughts about that. Yeah, here they are. Good. I'm so glad you asked, because
oh, great. Okay.
I have this thing that I would decided not to show you, but I would really wanted to. So let me show you this. So actually, one of the first things that got me involved in this part of the world was when I heard that some states were considering when I learned that 4 states have state policies of guaranteed issue and community rating, eliminating the pre-existing conditions for Medigap. And I thought, well, golly, there's 4 states, Massachusetts, New York, Maine, and Connecticut. I want to fight for Missouri to be number 5. And I started looking into it, and I thought, measure twice, cut once. And I measured twice and decided that's really a bad approach. But let me show you the 2 data points that persuaded me it's not a good idea. First, if you look at average monthly premiums for Medigap in the United States last year, it was $155, which is, I have last year's data for these states, which is why I'm using last year. It was $155. The states that have guaranteed issue average premium is higher, which is what you would expect, right? If you have guaranteed issue, then people that are going to pop into it are the sicker people from Medicare Advantage. You'll wait to buy Medigap until you're sick enough that you really think it's worth your doing it. So pretty consistently around the country, the states that have guaranteed issue, everybody in that state has to pay more for their Medigap policy. Is that good or bad? I mean, that's kind of what insurance is about, but guaranteed issue will jack up the premium significantly for everybody else. Is it still a good idea? I mean, does that mean, though, that we'll be changing the dominance of Medicare Advantage? Sadly, no. Here's the growth of Medicare Advantage from 2014 to 2024 across the country. The states that have guaranteed issue and community rating, Massachusetts is one, and it increased at the exact same rate. And the other states that have guaranteed issue and community rating actually increased their Medicare Advantage penetration more quickly than the average for the country. And I was puzzled about this for quite a while. And PNHP staff, Dixon, really, really smart guy, told me that what he thinks, nobody knows, but what he thinks is going on with this is that people are more comfortable going into Medicare Advantage, taking the risk because they have guaranteed issue. They know they don't only have that 12-month window. They know if they go into Medicare Advantage, whenever they're unhappy about it, they can go back and get out of it. So the data shows that states that have guaranteed issue and community rating have higher premiums and more Medicare Advantage penetration. So I would discourage you from adopting advocacy for those things as a target. I bet that's not what you expected.
Thank you. I'm looking at the chat. Let's see. Someone wanted to know if, where to go? Navigators are the same as brokers or different?
Technically, navigators are the technical term for that is for people who navigate the ACA marketplace.
Mm.
So insurance brokers are typically that what I was talking about were about Medicare Advantage insurance companies. But I don't think the words are always used exactly in that literal way. So a lot of people do talk about insurance agents as a navigator, and so there's some, but technically navigators is defined for the term that was really, I think, created as a part of the ACA to help define the people who help people navigate the ACA.
Right. Thank you.
And yeah, the comment about Kaiser, I mean, yeah,
Yeah.
there are, I tried to show that right at the beginning, people are generally happy in both. It's only when you get desperately sick that, and when you're really quite sick, it's not even, still a lot of people get good care. I'm not saying, but I'm just saying the odds are much worse. You're making a gamble, and just do that knowingly is all.
Hmm.
Yeah, Pam, yeah, that's right.
There's another question. Can you comment on the idea that if for-profit Medicare Advantage plans were eliminated, then traditional Medicare could pay for Part B for everyone?
Yeah, that came straight. I think that came straight. You read our report. That came straight out of the PNHP report that we looked at when we figured out that there was $140 billion a year of overpayments by these companies. We thought, I mean, I'm not an economist. Is 140 billion, is that a big number? Is it a little number? I don't.
Sounds big.
I don't know. It looks like a big number, and I would take it. I don't know I don't know if it's a big number, but so we tried to find reference points, and one of the reference points we found was we added up all of the premium. If you're when you're in Medicare, you get Part A without a premium, just for having paid your taxes into it. But if you want to go into Part B, you have to pay a premium that averages about $200 a month. More or less, and most people have it taken out of their Social Security check, so they don't see it every month. But we're all paying it pretty much $200 a month. Well, if you add that up for $200 a month for all, what is it, 50, 60 million people that are in Medicare, if you do the arithmetic and add that up, it's $131 billion. So we're Medicare Advantage companies are ripping us off by $140 billion. And all of Part B premiums are 131 billion. That's a smaller number. So when we pay our $200 a month, we think we're doing that because that's the only way that the federal government can afford to provide a Part B benefit. But actually, no, turns out that's the only way the federal government can afford to overpay Medicare Advantage companies. We're paying them to overpay Medicare Advantage companies, and that's not what I want to do.
So a couple more questions, and then I want to ask one at the end, but here's another one. Can Medigap policies raise their premiums at will?
Yes.
That's what I thought.
Yes, they set their own premiums. There is a limit, I believe, but they can set their own premium. They do set their own premiums. And they're all over the place. There's quite a range in price.
Right, all over the place. Let's see. Barbara Cummins says that she is a SHIP counselor in California and would like to share this with her fellow counselors. Can you send her the slides? I hope you can make them available to me, and then I can send them out to the whole group.
Yep. And Thalia, if I forget, please just send me a note and remind me. And I'm glad to have you all use these however you want.
Sure.
They're a lot more valuable when you use them than when they sit on my laptop.
Okay, great. When does the effort start at PNHP to stop subsidizing Medicare Advantage? I like the idea of the league joining in their efforts to do this. This was actually my question. We are a task force here, so we're action oriented, or we try to be, especially in the league. So we need more information about this bill being introduced in Congress, who's introducing it, which house, how can we, push the scales?
So we have written a bill to level the playing field that would add the missing benefits. It would add the low out-of-pocket maximum. It would end the subsidies, and it would do some other administrative things that are really, really important, but too arcane for tonight to discuss. But we've written that bill. The bill has been sent to the legislative council in Congress. We're hoping to get it
Excellent.
turned into language that then somebody in Congress can file. We are
Mhm.
still in the process of um,
Did you want to eat that?
encouraging a member of Congress to file the bill. So
Mhm.
it doesn't yet have a name or a number.
Okay.
And
Or
when
a
it does,
sponsor?
we will be screaming it out loud as we can.
Okay.
But what does definitely exist today is our plan to intervene on the Medicare Advantage rates,
Mhm.
early next year. So stay tuned, and we'll keep you posted. What you can be doing now about that is learning about it, understanding how they're paid, understanding how the benchmarks are, understanding why this is so important, and trying to find people, throughout the League of Women Voters who are willing to
Mhm.
engage come February or March, whenever this, happens, to
Mhm.
engage with members of Congress in district, meet with them in district and tell them, hey, we're going to be watching. CMS put out their actuarially derived numbers. The insurance company says they want more than that. We're going to be watching. Help CMS have the courage to stick to their actuarially
Mhm.
derived numbers. And we'll have a whole suite of tools and things to support you with that. But between now and then, the time is to start having these conversations and get people kind of sniffing around about it and
Yeah.
interested.
So how do we combat the insurance industry lobby? I mean, it must pour millions of dollars into congressional coffers.
Absolutely. That's a big problem. We have to fix democracy so that you can't do that. But
Mm.
at the end of the day, grassroots trumps them. I mean, the insurance industry, we have this quite a victory, last year, this past spring with the insurance industry, where they spent a fortune trying to get their Medicare Advantage rates jacked up, and we spent next to nothing because we don't have those kinds of resources. We spent next to nothing doing, all these congressional visits, and we won despite how much they spent on
It
lobbying.
works.
So it works. This stuff works. We can win. We just have to do the hard work. And,
Absolutely.
and I've got to leave in the next couple of minutes. I've got something
Okay,
else I
how
have to
about
do.
one more question?
Okay.
What factors account for the huge differential in premiums between different states that have passed guaranteed issue laws?
Yeah, well, I think it's primarily because I think the difference, the reason the premiums are higher is because people, um, if you're in a state that doesn't have guaranteed issue, and you turn 65, you kind of want to buy your Medigap policy as soon as you turn 65. And
Mhm.
if you're going to if you're going to go into traditional Medicare, you're going to buy your Medigap policy right away because you have no promise that you can buy one a year later. So even if you're healthy, you turn 65, you go into traditional Medicare because you heard some nitwit like me rattling on about this. So you go into traditional Medicare, and you need to get Medigap, and so you buy Medigap because there's no promise you can get it, when you get something bad in a few years. So in other words, a lot of healthy people, relatively healthy people, wind up purchasing Medigap in most states. In a state with guaranteed issue, you don't have to do that. You can not buy, you can save that $200 a month until you get sick.
Mhm.
And then when you get sick, purchase Medigap, or leave Medicare Advantage, go back to traditional Medicare and buy Medigap. Or even if you're just in traditional Medicare, you might not have purchased Medigap because you're healthy. Why
Mhm.
spend $200 a month because you can go buy it later if you need to. So in states with guaranteed issue, it's a sicker group of people that tend to want to buy Medigap, and if they're sicker, they're more expensive, so the premium is higher.
Mhm.
So sort of an unintended consequence, and I
Right.
really do need to move to go. I've got another thing that's over
Oh,
that
sure.
I'm just starting to do. But thank you so
Thank
much.
you.
I really
Thank you,
appreciate this.
Dr. Weisbart. It's been very informative. I really appreciate your time and your expertise. We will get the slides to everyone that's registered for this meeting, and hopefully we can continue this conversation every month.
Oh, thanks.
Thank you.
Bye.
Bye-bye. Okay, everyone, it's time for dinner in Colorado. How about for everybody else? I'm going to sign off, and if anybody needs any information, just email me at healthcare@lwvcolorado.org. Thanks. We'll see you next month.